Hello, thank you very much. I hope you're all refreshed with your coffee. I'm Robert Moss, I'm a hospital pharmacist, and I'm here on behalf of the Dutch Hospital Pharmacists Association, and giving the lecture actually on behalf of a working group that has Rinske Pauw, Channing van der Schot and Michael Duivendak as experts in it. And contrary to most of the talks now, it was about big systems, big supply chains, and I want to drill down slightly. Because the Dutch Association of Hospital Pharmacists, they made a statement this June, and this is probably the reason why we are here to tell it. And now I'll start with the statements. Dutch people are bold, we always come with the things immediately. This is the statement. We would like all medications used in hospitals to be available in single unit-to-use packages, so unit dose administration at point of care is possible, and we would like all single units of use packages to contain a correct barcode. So the record can be recorded, the administration can be recorded in the medical files, and it would significantly contribute to greater medication safety. What do we mean with single unit of use? You're probably familiar with the term. Just to say, it's a package that where every tablet or unit of use is packaged as a single unit and can be opened and dispensed without the use of any tools or instruments. So easy to use. For labeling, we would like to have every unit of use to have the name of the substance, the strength, the expiry date, the batch number, and if necessary, the method of administration. So at the single dose level, we would like a barcode in GS1 data matrix format, including the GTIN expiry date and batch number. And in our statement, specifically, we mention the adoption of the GS1 standard in all areas of healthcare. Yep. So, in short, this is it. The primary package should have a DSH matrix. That's basically, if you go away with that this is what we want and this is what we're going for, that is the essence of the talk. So why do we want this? It was mentioned in several slides, in several presentations. It's all about patient safety. I'm very passionate about having a very efficient healthcare system, but also a safe healthcare system. So it's all about having quality from, of course, the whole supply chain, but specifically also at point of care and within the whole health registration. We've seen these, I'm just trying to, yeah. We've seen this, of course, the rights of the patient, having it at the right time and everything. All of this is not possible if we don't have the right, oops. It's going very fast. If we don't have the right methods and the right means to do it. We've seen this picture in several points, but I'm going to drill down a little slightly more. This is the process that is typical of a hospital and the medication used. It's a doctor prescribing, a complex process, and a pharmacist checking, correcting, and then it goes, finally, it should be the nurse who delivers the care that was typically made by the pharmacist and the doctor in a collaborative way. But the important point here is that the nurse, at this point, there's another chain coming in. It's the logistic chain. The order gave a logistic order, and at this point, at the nurse's point, this is where everything should come together. It's the prescription, it's the logistics, and this is where we should register that things were administered. And until now, the system still depends on manual labor. We know with optical failures, people are not very suitable at reading accurate information. Oh, it's going very fast. We tend to associate, we tend to think things are right. So we do look at things very quickly and we think, okay, yes, it's right, so we administer. And we, as humans, unfortunately, are not very adequate at this. There is also the sound alikes. There is quite a difference whether you give a drug that is dissolved immediately and taken up immediately, or whether it's a controlled release. It could mean the difference between either working properly at the point of care for the patient, or even if you give one dose of a non-controlled release substance in the dose that you give a controlled release, it could be fatal. This, of course, specifically holds true for the high-risk medication, that if there is a failure and it's ready to administer, if this is wrong, this is potentially very, very dangerous. All medication errors in the Netherlands are recorded in a national database. So every hospital has a standard way of reporting to a national database, and all medication errors are reported and collected by this national data in this national database. And as you can see, most errors are made during administration. The interesting part is the blue is the benchmark, that's the national part. The yellow part was a hospital that already had some bedside barcode scanning, and you'll really see that this is slightly, it is not fully operational, but you see the administration part going down already. So why do we want it? What is proven in this sense? Several studies have been done about bedside barcode medical administration, and basically the important part is that if you can properly register or make sure that the nurse is giving the proper medication, there would be a 30% fall in serious medication errors. And if you have barcoded electronic medication administration, there would be a 51% reduction in errors. So we want scanning on the ward, but scanning that is from A to Z, from knowing what is prescribed, knowing the right patient, knowing the right drug, and having it in your administration, that you have a closed loop, that it was given and it did have the effect that we wanted. So if there is a wrong dose, it should give an alarm and people should go on. It's not only during the administration, it's also the preparation. On the wards, a lot of drugs are reconstituted. Now there are very cumbersome systems that you write parts, you have to scribble on a file, which is probably usually lost because we don't know how to save it properly. But having barcoding and automatic systems would also have preparations on the ward, efficiently administrated, so we would know exactly what was given. This holds true if you reconstitute. It also holds true if you make drugs from several other drugs, combined drugs, and for instance in your manufacturing unit, but also on the ward, you want every unit to be identified that was in it. You want to be sure that this is what was given to the patient. One part is hospitals, and of course as a hospital pharmacist I'm very avid about hospitals having this system. I think the time is now right, because we are more and more, a hospital is a very short-term facility where people are hopefully, or well, not hopefully, but they are very ill, and as soon as they're slightly better, they go out either to a nursing home or even more often afterwards into home care. And I think we are really reaching the point where the health systems cannot afford having everybody in expensive homes. So more and more, and in Holland it is already starting, people are pushed back home, and there are people having to take care. And more, these will be young people looking after elderly people. And this time of the age, more and more technology is being used. So it will be absolutely, they will want double checking whether the administration was right in the healthcare. So it's not just a hospital problem. It is now becoming a wide problem for the whole healthcare system. So what is the current status? As you can see, it's a bit of a mess. There are all different kinds of packaging and no standardization. one hospital did an investigation, and they had 212 stock keeping units. You would say G-tins probably. Or you would say, no, it's not the G-tins, it's a specialized unit. Well, it would be G-tins. So it's about 3.5 million units dispensed per year. Most of these are solid capsules or tablets. Of the overall stock keeping units, 59% did have a barcode and 42% didn't have a barcode. If you look at stock keeping units that were dispensed, I must say it was 81.5% that a large majority did have a barcode. That's because in Holland we already use a single dose, which is we buy it from a company and then the wholesaler repackages it. And with this system we have an 81%. So our aim is having every unit of use barcoded. Why isn't this the case, actually? Because we're all here and we're all agreeing that it should be done. Every unit of use should have a barcode and it should be a GS1 standard barcode. But why isn't it happening? It is because people were saying, but the industry was saying, if we produce this, hospitals can't even do anything with it. We'll do it, but nobody can scan. In Holland, and this is why the time is favorable, we do have an optimal system because almost all of our, well, I could say by now 100% of our hospitals have electronic systems. Most of them have CPOEs, the prescribing, electronic prescribing. Many systems are already in place to do barcode scanning at point of care, yet the system is not ready for it yet. And it's going very fast. In 2003, there was one hospital who was experimenting this. 2011, there was a second. 2013, there came some more. But now is the time that we are really advancing, and we are waiting for units of use being barcoded. This is not directly linked to unit of use barcoding, but it is a tremendous opportunity to falsify the administration, because somewhere in the process you will need barcode scanning. So you will be redesigning your process as it is. So this is the moment to look at the point of care part too. So once you're redesigning, this is the time to really redesign the process so you can have barcode scanning at point of care. Is the Dutch Association unique in this? No, because we've heard many people speaking about this already. The EHP, the European Association of Hospital Pharmacists, has been mentioning it and advocating it since 1987. But just recently, because technology is advancing so fast, they've updated their policy and they now have a statement on barcoding of single doses. They have, I think, a very nice policy briefing about unit of dose barcoding. And internationally, I mentioned the FDA here, but you hear many systems here. People are ready. We do want unit of use dose barcoding. There's no possibility to not want it and not implement it anymore. So we want it fast. And what do we need? Again, we need single units of use packages that have, for all drugs administered, the label should contain a non-proprietary name, the dosage form, the strength, the control number, or a lot number, and the barcode, preferably a data matrix GTIN. All this said, it's wonderful, but we cannot do it by ourselves. We can make a statement, we can put it down, but we do need to work with others. And I think this is also why the Dutch group was asked. We are doing this because we are trying to get everybody involved. Manufacturers, government, regulators, healthcare professionals. We too have a national drug database, of which we're very fortunate. They're into the game. So we're trying to reach a covenant with everybody saying, this is what we want. Please give it to us. And what are the difficulties and how can we solve them? There's a prioritizing of high-risk medication, and After that, we would like identification of all single-use medication, and there's the last step, but not unimportant, a batch number with expiry date. What would the outcomes be if this ideal world would come along? It would be medication safety up to the point of care. Again, it was said, but you could do possibly recalls at a single dose level. What I haven't mentioned, that we have to register all biologicals by batch number. Until now, that is always done manually. So this would be made possible, and there would be solutions along the continuum of care. So again, I'm very avid, and I think the Dutch made a big statement here. And I do hope that everybody supports us in this, and that it will be a reality in the coming years. And GS1 will be part of the solution. Thank you very much.